results on signal functions that have been performed and reasons for non-performance of the signal functions. So as an update, we are happy to report that regarding the trainings, all the 3 counties have included their EMOC trainings in their annual work plans 2022-2023. Uasin Gishu is yet to conduct the training, but Vihiga and Garissa have had the trainings. There's a pool of trainers who have continued to support these trainings within these counties, and they're also called upon to support trainings outside these 3 counties. And we were also working with counties to mobilize resources for establishment and equipping of the EMOC skills labs at the health facilities. We are happy to report that Garissa County Referral has renovated a skills lab, a room next to the maternity unit, which is now working as a skills lab. The LSTM contributed to some of the furniture, and the renovation was done by another partner. This is a hospital that said our priority is a skills lab, and they sought support to ensure that it's equipped and functional. Then for post-training mentorship, we are happy to report that Uasin Gishu and Vihiga have not only continued doing the mentorships, but they've expanded these mentorships beyond the LSTM focal facilities. In terms of county support towards EMOC mentorship, this has been very good. RH coordinators have continued to share reports on monthly mentorship that is conducted in each of their facilities. They've continued to compile and share with us as a partner, so that means it's continued even with minimal support or no support from LSTM. The WhatsApp groups, very active. Then counties are also committed that they would look at the periodic reflection and learning events from mentors, whereby mentors come together and just sit and reflect what is working well, what needs improvement, and how can we move it forward. Uasin Gishu was very innovative. They had a virtual one. Mentors joined virtually, and they had their reflection event. So that was very good, Uasin Gishu. Vihiga has had a physical meeting with the mentors, and it's also a way of sharing knowledge and also planning for the next steps. In terms of EMOC functionality assessment, during our in-service session, we heard that MOH is working on digitalizing the tool. So we look forward to seeing that. Ultimately, MOH would like that tool to appear on KHIS, so that when you sit in Nairobi, you're able to know if how Garissa is performing with their EMOC signal functions. Then in terms of LSTM technical support to the counties on EFA data management, in the previous KMLs, counties had requested us to support them on how to use the MOH tool. LSTM has developed reference guide on how to use the MOH EMOC functionality assessment tool. So that is done. And in terms of counties conducting EFA, counties have been able to conduct the EFA, the 3 counties, but as I mentioned, the challenge is data analysis and reports. So much as they've collected the data, they have not yet analyzed the data, except for Vihiga. Again, congratulations, Vihiga. They were able to conduct the latest report and the latest analysis and disseminated the report. When we were in Vihiga in November at the Knowledge Management and Learning event, we were told that whatever you appreciate, we'll appreciate, and whatever you do not appreciate, we'll begin to depreciate. And that was one of the reasons why we were encouraging counties to actually appreciate their outstanding staff and health facilities. Counties committed that they will do this on an annual basis, and we are happy to report that Ijara Sub-County Health Management Team conducted their award ceremony in December 2022. They recognized the best performing health facilities and the best performing healthcare providers. In a very simple way, they invited these people to their office and gave them certificates. So Kotile was the best performing health center. Congratulations, Garissa, for taking that forward. That is a simple certificate of recognition that was awarded by the sub-county management team to Kotile Health Center. The HR dashboard is a county strategy for managing staff retentions. We're happy to report that the 3 counties have adopted this as a tool for managing staff retention, and we are making at EMOC trained staff within MNH units. On a quarterly basis, this dashboard is updated to see the status of EMOC trained staff. Where are they, if they're in MNH or they're not in MNH? And it has also been used to identify which facilities are to be targeted for trainings. So just as an update, Garissa has been championing this agenda. The RH coordinator, when she goes out to the health facilities, she's been using this opportunity to sensitize her facility managers on the importance of ensuring that EMOC trained staff remain within the MNH units, or if they're to be transferred, there's at least people they have mentored before they are transferred. Vihiga has also used this dashboard to make decisions on staff promotions. One of the mentors who had done very well in a facility was actually promoted to become a sub-county RH coordinator, bearing in mind that she had actually mentored people in her facility who can carry on with the mentorship. Uasin Gishu has also, Vihiga also used it to second a mentor to one of the facilities that had an internal challenge with maintaining staff. So we see that the HR dashboard is actually not only being updated, but it's used to inform decision making. Uasin Gishu also has used it to inform decisions on one staff transfer. So that slide just illustrates the dashboard. Baseline was the baseline in blue was done in August, and the one in December, that is the update. And we see that Garissa has had a slight improvement in percentage of staff working in MNH units who are EMOC trained, and it's also similar across the counties. So the dashboard is in use and it's helping. It's not sophisticated, as Lucy said yesterday. It's a simple Excel sheet. So in conclusion, as LSTM, we are confident that the counties have a level of inbuilt sustainability to be able to continue conducting EMOC trainings, facility-based mentorship, and utilization of the HR dashboards, as well as the EFA quarterly assessments. However, we continue to recommend that National MOH digitalizes the assessment tools and supports the counties in equipping of facility-based skills lab. For those of us who are in the in-service work stream, we learned from MOH that they have big plans and they have received partnership support in order to equip skills labs, so that is good. And then we also advocate for medical schools to incorporate EMOC and advanced obstetric skills within their curriculum. Otherwise, we appreciate all our partners who have come with us this far, and not forgetting again the frontline healthcare providers. Thank you.
Yeah, so thank you very much, Irene, for that elaborate presentation on the plans for sustaining the gains so far out there in the field in terms of the in-service work. Now we give opportunity to Duncan, the chief educator, to continue where he left. Many proverbs are welcome. Thank you.
There are no hyenas in the house this afternoon. Suddenly, I can't see the presentation again. Great. Good afternoon. Sorry for wasting time, and I hope I'll not waste much time here. You know, a man who has been accused of stealing a goat cannot entertain his guests using goat meat. So I'll share some transition plan on the pre-service work. I'll give a few lessons we've learned during the implementation, and then in the transition, I'll share something around the curricular review, capacity strengthening, students teaching, equipment, and CPD work. As part of the lessons we've learned during the implementation of this work, there's really need for us to integrate teamwork for all the skilled health personnel, people who work within the maternity units without focusing on one cadre and leaving out the other. And we are talking about the clinical officers, midwives, and also the medical doctors, just as outlined, as defined by the WHO and all the other stakeholders as a skilled health personnel. It's a collection of team members for them to be able to work together for the benefit of the mother. And then while giving these updates, we should always remember to integrate between pre-service and in-service, because when there's a harmonized teaching, then there's a harmonized practice. Yesterday, we had a comment from one of us here that sometimes you receive students in the clinical environments and you are wondering where these students, whether they have been coming from, whether they have been attending a class. You see, when you receive such and you are always getting these updates, as the in-service team, what do you do to these students and to the educators? Do we just sit down and blame the pre-service guys for not being updated? So as in-service working within the facilities, when we have opportunities to get these updates, we are always attached to teaching institutions. Why not call colleagues from the teaching institutions to be part of the team receiving these updates within our institutions? Then the second aspect is around curricular reviews. One of the institutions we visited told us that this was the first time a curriculum has been reviewed and educators followed up to be sensitized on exactly what had been included and also taught on how well to deliver it. So we think this is a practice that should be integrated and continue for all other future curricular reviews. Then training alone is not sufficient to maintain competencies. I was just telling the other group in the pre-service team that Ahigot has one of the best beards in the world. But if the beard was everything, this Ahigot could preach. For these trainings, we pump so much into the trainings, but training alone cannot be sufficient for us to maintain these competencies. We need other systems. We need the CPD systems. We need the mentoring systems. Our educators and our practitioners need access to systems where they can be able to update their skills and competencies. And this is something we are calling, we are working together with the relevant regulators and the institutions to ensure that these are things in place for people to have the capacity, at least access to regularized capacity for improved practice. Then as we work, we should always endeavor to strengthen both the public and the private institutions, because we are all players in provision of healthcare, and we should be able to work in harmony, because when we work in harmony as private and public, it's the final woman and baby who ends up benefiting. And so as part of the sustainability plans and as part of the transition, there's the aspect of curriculum. I'm happy that for Kenya Medical Training College, this is now something within their budgets. They are able to budget and have these curricular reviews. And once we have this, there is also a plan for them at least to be updating the lecturers once they've updated this curriculum. We hope that this is a practice that can be taken up by all the other players, such that we have these regular updates on curriculum, because so many things are happening within our country, and we need a structured platform at least to legalize, to ensure such things are integrated for good practice. The second aspect regards the capacity strengthening of our educators within our institutions. A number of opportunities have been provided, including peer teaching and support, where some of them have been trained around the issues to do with peer teaching, and they can be able to support one another within the institutions. Looking at our trainings, we used to train clinical officers and nurse midwives within these mid-level training colleges, and we believe there is an opportunity that is already being witnessed in some of these colleges, where they all team up together and train these students on the same skills, such that by the time, we always say, we always have these deficiencies in terms of the teaching faculty, but when the two departments team up together, we are able to achieve more within a shorter period of time. And then there's need for us to have this on-site mentoring of our educators, and I'm also happy that within the KMTC setup, there is a plan for the regional training hubs, based on the former provinces, whereby at least people from a certain region will be teaming up together to just build the capacity of their educators in key skills, both teaching and also emergency obstetrics and newborn care. In terms of skills, there is need, LSTM has provided equipment to the training institutions, but there is need for us to maintain this equipment, because after they have been used, there are those wears and tears, but there is always need for us to have at least good storage and maintain a regular inventory of these equipments and functionality. And I know in some of the institutions, efforts are underway at least to have people who can support in terms of managing this skills lab. But even as we get these people on board, there is need for us to sensitize and at least take them through some training on what some of these equipment are and how well to maintain them. One time we went to an institution during our mentorship visits, and the mentor requested one of the skills lab attendant to bring us a stethoscope because it was very key for the skill he wanted to lead. Our colleague brought us a microscope after hesitating for a while. So when such things are happening, it's not like, for him he knows a scope is a scope. Whether it is a stethoscope, is a microscope, a scope is a scope. So there's need for us to sensitize and educate people on what exactly we are talking about when we have these equipments, such that we can have a harmonized practice. Then, practical teaching of students. This is an area where our educators, both from universities and also from the mid-level colleges, have had several weaknesses here. People are so good in theory, but when it comes to the practical aspects, this is where we have some deficiencies. Some of the things we have in place is that we now have equipped skills lab, and there's need for these educators to have these skills demonstrations for students before they proceed for their clinical placements in the wards. And then some of the institutions have also had student facilitators. Some students have been identified to be so good in specific skills, and these are students who are helping to train their fellow colleagues. And this is something that is also helping us to manage areas where we have insufficient faculty. And students, some of them have really commented that when they are being taught by their fellow students, it is very easy to even ask questions and strive to achieve the same competencies as their other colleagues. And then follow up on students during clinical placements. Now, it's also difficult for a lecturer to follow up students when he or herself is also not competent with the skill to be followed. And there is a very good plan for our educators to also participate in these clinical placements and practice for them to improve their skills, such that even when we go for the clinical supervision of students, then we are also updated with what is happening around. And lastly, there is the continuous professional development. As we speak, a lot goes in around training, but this is something that depends on the available funding. But then we need this system in place such that it is a sustainable system for educators to be, at least to have an opportunity to update their theoretical skills and also the practical skills, including the principles of teaching and learning for effective delivery of content to the students. And also, this will be an opportunity for people to update themselves in terms of their knowledge and practical skills in their teaching competencies. Guys, thank you so much. I wish to acknowledge our partners who've supported us to this end and all the stakeholders who have participated in ensuring that as pre-service, everything starts around pre-service before we get to in-service. And therefore, the efforts around pre-service are greatly acknowledged. Thank you so much.
Thank you very much, Duncan. The impression I get is that either there are many sages in your village, or you have too many goats, or, you know, there's always something around the goat, but we really enjoy those sayings. Yeah. So we'll go on to the last presentation on transition plans for MPDSR. It will be made by Madam Scholastica Wabwire from the Ministry of Health. Welcome, Scholar.
So I will take you through the transition plan for MPDSR, and so this is it, okay. So the outline is as follows, that we going to look at why we should have this transition plan and the key activities in the transition plan. We're going to look at CMD versus MPDSR and also the way forward for Kenya. So why the transition plan? Ni rewind. So why the transition plan? As you're all aware of, the FCDO-funded MNH program is coming to an end by the end of this month. And the transition plan is to inform the process of the institutionalization of MPDSR activities at the national level as well as the county level. And then it also will provide the pros and cons for the CMD and MPDSR process. So the key transition activities are as follows. Number one is handing over the National Secretariat Office to the Ministry of Health. Number two is about the monthly National MPDSR technical team meetings. There's a modality on how this will continue. And then number three is review of the retrieved and anonymized maternal death files.
review and documentation of the progress in the implementation of the first CMD recommendations, integrating MPDSR activities into routine QOC framework, as well as participating in the knowledge, management, and learning events, including podcast production. So on handing over the National Secretariat to the MOH Division of Reproductive and Maternal Health, one of the requirements or one of the activities that is undertaken under that secretariat is convening the monthly MPDSR technical team meeting. And LSTM will continue to convene the monthly national MPDSR technical team meetings with the MOH. And this means they can't just off and go. The transition has to be progressive. So as they hand over, they can't just hand over everything and move. So we will continue they will convene the monthly national MPDSR technical meetings with us. And these meetings present a forum for discussing the transition plan, as well as receive updates from partners on the ongoing activities supported by partners on MPDSR. So review of retrieved and anonymized maternal death files. The Secretariat has supported training of 93 maternal death assessors from all the 47 counties. And the assessors have been taking part in the review of maternal deaths since 2015 through a series of regional workshops. The CMD report has served as an advocacy tool for the Ministry of Health at both the national and subnational level, that is the county level. And as part of the process geared towards the production of subsequent reports, the MPDSR Secretariat has retrieved the anonymized maternal death files from the 47 counties for the years 2017 through to 2020. So the maternal death files from 2017, the year 2017 has been assessed. And we need to put measures in place to facilitate the review of the remaining files, that is for 2018, 19, and 20. And these are a total of 1,483 files. So this is the status of the maternal death files retrieved and assessed since 2017 to 2020. In 2017, we were able to retrieve 575 files, and we were successful in assessing all the files. So we do not have any pending files for 2017. 2018, we retrieved 675 files. We were able to assess 452 files. The pending files here are 223. 2019, we retrieved 580 files. We have not assessed any of these files. And also for 2020, we have 680 files pending. So we have 1,483 files that are pending, and they need to be assessed. This is about over 50% of the files we collected since 2017, the 2017 files to 2020 files. So status of maternal death files retrieved and assessed, this is a continuation, is that previous experience has indicated that we only require 4 days assessors workshop to review at least 250 files or assess 250 files. And for the pending files, it will take at least 4 days assessors workshops to completely assess the remaining files. And the budget for each assessors workshop is about 2 million, and that translates to 17,000 USD. And if we are to have 6 assessors workshops, then we require a total of 102,000 USD, and this translates to at least 12 million Kenyan shillings. So we are in the process of lobbying for M&A for support from MNH MPDSR partners because we need these files to be assessed. On the progress in the implementation of the first CMD recommendations, specific sessions for discussions on the progress on the implementation of the first CMD report recommendations, this has taken place, and this we've done in detail this morning. We have discussed this. And we have to acknowledge that we have progressed so well after with the recommendations for the first report. And we also have published, we have a blog, and there's a case study for wide sharing. This emanated from this first CMD report. On integrating MPDSR activities into routine QOC and MNH accountability mechanisms, as part of the sustainability of MPDSR activities at the national level and the county level, the MPDSR technical working group members will lobby for the integration of MPDSR activities into the annual work plans by county and national levels. This is already happening. I'm sure this is happening at the national level, and of course the Transforming Health Systems, that is THS, funding also supported counties to have this in their work plan. So this will also ensure the activities are included in the QOC MNH accountability frameworks, and also integration of MPDSR in pre-service training of healthcare workers. Looking at the pros and cons of CMD and MPDSR, for MPDSR, it is conducted by health facility staff who took care of the woman who died. And there are difficulties within MDSR teams to critically review these dates, and evidence has shown that multiple components such as facility audits, development of local leadership, and training of health providers is likely to reduce inpatient maternal mortality in district hospitals and slightly improve quality of care. This is by Wilcox et al. 2020. However, conducting death reviews in isolation may not necessarily result in reduction in mortality. Maternal death audits may need to be implemented as part of an intervention package, which includes training of a senior doctor specialist, a midwife in each hospital, and annual recertification and quarterly outreach visits by external mentors to provide point of care supervision. And this is also from that study recommending that. For CMD, this is independent multidisciplinary anonymous investigation. So there's lack of standardized methodological definition of how to conduct a CMD process. And some studies have shown that there's usually confusion in some quarters between MPDSR and CMD. So countries in low resource settings have set up CMD processes with lessons from the UK CMD process. And implementation approach for each country are different and deviates from the UK implementation model. While all maternal deaths in the UK are reviewed and action taken to improve care and reduce preventable deaths, for resource-limited settings, not all maternal deaths are reviewed because of poor record keeping. You will find that sometimes you have missing files, poor record keeping, maybe the notes are not complete. So what do we do about all this? And this is our way forward, that MPDSR and CMD are important because they complement each other. WHO recommends the production of annual MPDSR reports. We had our first annual report, 2019, and we are hoping to have our second very soon. UK and South Africa produce their CMD report every 3 years. For Kenya, we recommended that we produce these reports every 2 years. And there are discussions ongoing on the review of the MPDSR guidelines, as well as the MPDSR training packages. So just to emphasize that MPDSR is a postmortem of asking why did the woman die. Integrating the MPDSR activities into routine QOC and MNH accountability mechanism of MOH is critical, because in most of the MPDSR audits, maternal death audits, in the recommendations, we find that it is, the reason why the mother died, it was because of substandard care. So if we are able to integrate these two, maybe we'll be trying to take care of the quality of care aspect in the recommendation. As part of the sustainability of MPDSR activities at the national level and the county level, the MPDSR technical working group members will lobby for the integration of MPDSR activities into the annual work plans by county and at the national levels, and this is ongoing. And also sustainability of the CMD process is a major challenge, but this will need a concerted effort and pooling of resources between the MOH and development partners, as well as implementing partners. So there's still so much work for MPDSR. We've made great progress with support from LSTM and other partners, and we hope to continue with other partners in the same way and maybe even come out stronger. And with that, I would like to acknowledge all the institutions who are presented by the logos outlined there. And I think I'll Photoshop myself to be fitted in that, in this photo. Thank you very much.
All right. Thank you very much, Madam Scholastica. We really appreciate your presentation. So we are basically coming to the close of the meeting, but before we conclude, we have one pending activity. That is, we are going to have a panel discussion, and this is the opportunity to clarify a few final things and maybe field some questions to the panelists.